afternoon, everybody. We're just letting some people trickle in and we'll get started shortly. Thanks everybody for joining. We're just gonna wait a couple more minutes for everyone to get settled in, and then we'll get started in a couple minutes. Just wait maybe another minute or so and then we'll get started. All right, it's 2 minutes after 2 right now, so we'll just go ahead and get started. First of all, welcome and thanks everybody for joining us today. My name is Samantha Bai. I'm a clinical scientist here at Hyperfine, and I'm going to be the moderator for today. So 6 years ago, our founder, Jonathan Rothberg, came to a team of scientists with the mission that you see on this screen here today. And that was to democratize healthcare by making medical imaging accessible for everyone around the world. And the crux of the matter is that MRI, while it's one of the most information-rich imaging tools out there, it's really largely inaccessible. The Hyperfine system, which received its first FDA clearance in February of this year, addresses that. It's a system that is built on wheels, and it's designed to go from bed to bed and requires almost no siting requirements. So that means no dedicated room, no MRI or radiology technologist required, and it's controlled completely by an iPad. The scanner plugs into a standard wall outlet for wall power, and with the maximum power required being the same as a kitchen appliance, similar to a coffee machine. And it's low cost, far less than the service contract of most fixed conventional MRI systems. So today we have a panel of 3 emergency medicine doctors who will share their experiences with the Hyperfine scanner. They'll each provide a 10-minute presentation followed by a Q&A session after all of the talks. You can enter your questions in the Q&A window, and we'll either answer them live or someone will answer them via the Q&A window. So without further ado, I'll give the floor to our first speaker, Dr. Charles Wira. He's an associate professor in emergency medicine at the Yale University Hospital in New Haven, Connecticut. Charles, the floor is yours.
Hi, thank you very much, Samantha. So just as Samantha said, background about myself, I'm an emergency medicine physician at Yale, but I also take stroke call as well for our stroke program. I do have some volunteer positions. I'm a volunteer chair of the American Stroke Association's Emergency Neurovascular Care Committee, and then I'm a member of the Stroke Council Leadership Committee as well. And very excited to speak about this novel device that is in the works. Next slide, please, Sam. As many of you know, there's been a tremendous progression of stroke care, most notably over the course of the past 5 to 10 years, where we have better technology and better interventions for our patients in this novel reperfusion era. And most notably with the DAWN and Diffuse 3 trials that have extended the thrombectomy window into the extended window. And I really do believe that Hyperfine is going to be, is now a headliner that banners on a slide like this with the novel things that may be able to be done in the early hyperacute phase, where we are trying to get a most accurate diagnosis to establish patients most eligible for acute and hyperacute phase interventions. Next slide, please, Sam. And so as many of you know, MRI has had kind of growing utilization for many acute neurological emergencies. We have the work by the Wake Up Stroke trialists in Europe, and by Ona Wu's group at Mass General, looking at this, what's called a diffusion flare mismatch in acute ischemic stroke. And for background information, as many of you may be aware, you can see an immediate, within 5 minutes, restriction of diffusion on MRI, indicative of acute ischemic stroke. However, the flare sequence abnormalities may take 4.5 hours to appear. And so thus, as has been coined by investigators at Mass General, the MRI can serve as a witness as to when stroke onset has occurred. And there have obviously been some positive wake-up stroke trials, but there's potentially future further research necessary before we can have knowledge about definitive therapies and eligible patient populations for this. But Hyperfine will certainly make it much easier for patients getting acute, hyperacute phase access to early MR imaging. Also as well, many emergency departments have rapid TIA protocols, of which MRI is a crucial part of that decision-making, because it can differentiate patients that have small strokes on cerebral imaging versus no strokes, and it can also contribute towards understanding what the etiology of a patient's symptoms may be, i.e. if you see restriction of diffusion in both hemispheres, it could be an embolic mechanism. As many of us in emergency medicine know and see on a daily basis, we see dizziness patients who are greatest fears that it could be a posterior circulation syndrome. Bringing an MRI to patients in the early phase can help in that population. And then utilizing the restriction of diffusion can, for some patients with questionable presentations, may be able to rule in or rule out stroke mimics, and also give critical information in identifying patients for thrombolytic therapies. There's also potential of hyperacute phase MRI technology for other disease entities, for instance, cervical spinal cord injury, orthopedics, and also maybe for early hyperacute prognostication for out-of-hospital cardiac arrest survivors. Most emergency departments, and certainly ours at Yale, only have remote access to MRIs. And perhaps some of you work at hospitals that are like ours, where it's almost akin to a 2-mile trip to the magnet with a very sick patient who may have to receive thrombolysis or go for thrombectomy after an MRI confirms that there is a stroke. For certain patient populations and just in general, it's common sense that it's safer for our patients if we can bring a magnet to the ER and prevent these long trips that also arise and lead in a consumption of resources, staff, and other entities for making such hyperacute protocols possible. Next slide, please, Samantha. And so, as has been introduced, we have this point of care MRI, and just background information about it. It's 64 milliteslas. It stands about 55 inches tall. It does have a magnet that has a diameter of about 5 feet, and it has imaging sequences of diffusion, T2, which can see pathological findings on MR, such as tumors, etc. It has flare sequence imaging. It has a scan time total of about 35 minutes. It's operated by an iPad. And for noise factor, because this is one of the first things that our nurses and techs asked, how noisy is it? It has an initiation alarm that's probably about as loud as a ventilator alarm. But then for the most part, the following sequences have a noise level that's comparable to most other emergency department monitors. And the device can be used for brain, cervical spine, and certain orthopedic applications. Next slide, please, Sam. And what we've done at Yale, really giving full credit where credit is due, we first deployed the portable MR device in our neurological ICU under Yale's primary investigator, Dr. Kevin Schath. And he's done a number of scans on triple-digit number of patients in the ICU setting. And really more than anything else, myself and others kind of joined this piggyback pilot study by which we translated the things that Dr. Schath was doing in the ICU to the emergency medicine phase. We got to the point of scanning one patient in our department, and then the COVID pandemic hit, where our hospital swelled like maybe some of yours to 500 plus patients. All research was put on pause, so we have not done a second scan in our department, but we look forward to getting the pilot back on track and utilizing it in emergency department patients with acute ischemic stroke, but also extending it to ICH, SAH, subdural patients and patients with intraparenchymal hemorrhages. And potentially we may also extend and do a pilot in patients who are out of hospital cardiac arrest survivors. You can see a picture on the right of the Gauss line that's extended. That kind of signifies where the field range of the magnet ends. In the middle picture, you can see an image in one of the neuro ICU beds where a patient is undergoing a scan. And then on the left, you can see in the ICU setting an intubated patient, a patient who also was on monitors, infusions, and drips, was able to have this scan performed. Next slide, please, Sam. And so what lessons have we learned so far in the translation to the emergency department setting, and what future directions are we going to be taking? Well, first and foremost, there was really an embracement of great enthusiasm from staff, faculty, residents for having this technology and for being a part of such a novel pilot project that has such great potential at being beneficial for patients, but then also making workflows more efficient in the emergency department setting. We have had several nurse champions who have helped us advance this effort. And along the lines of the enthusiasm, we've done actually several scans on 3 of our residents, 5 or 6 of our nurses as well, and our medical director as well in the emergency department, just as a demonstration of the device. 2 of the obstacles that we kind of worked through to overcome that I suspect many other emergency departments must face is storage, because as many of you know, hospitals real estate, and more specifically emergency department real estate, is among the most expensive and utilized real estate in any city or rural setting. And so we scoured our emergency department and we could not find any place where we could store the device. And this is in spite of 6 years ago having a renovation that added 75,000 square feet to our department. Ultimately, we found a place where we could store it in ER radiology, which is for the most part 45 feet away from our resuscitation rooms. And we worked with Hyperfine to create this aesthetically pleasing storage container, which is utilized. And some of our concerns, we didn't want to have the device left out in the open because, like many of you experience in your emergency departments, there's often psychiatric patients or other patients who may run throughout the department at times and have a parade of security officers after them. And the last thing we wanted was for one of them to jump on top of the device. So we had to find a way to not only protect patients, but also to protect the device as well from the sometimes moments of chaos that can occur in our department. Another challenge that we had to work through with our hospital leadership and nursing leadership was where to scan these patients. And for background, I mentioned our department at Yale, we kind of have 3 different pods, A, B, and C pod. The A pod is a critical care area with 19 beds and 4 resuscitation/trauma rooms. And it can swell sometimes to having a total of 55 to 60 patients if every hallway spot is utilized. And what we discovered was that in times of surge, which unfortunately, as the national and worldwide trend has come, in times of surge, we did not have an adequate amount of space to transport the Hyperfine device to individual patients' rooms. So we created a protocol by which we would use our resuscitation rooms. For background, our resuscitation rooms are big enough that they could be doubled up in a disaster for running simultaneous traumas, et cetera. But we've created a protocol by which we could scan in our resuscitation rooms, and that those rooms had easy access with a minimal bypassing of hallway patients. For the future, we look forward now with Hyperfine going live to integrating it into some of our protocols. The longer term hope is that it can potentially replace the hyperacute MR protocol by which, as I said, a patient is transferred emergently to a remote magnet in our cancer center to get a hyperacute study. We also hope to integrate it into our TAA protocol, which we use 2 to 3 times per day. We're talking as well about determining who performs the scans. Right now it's being done by the cadre of NICU research associates who have been involved with Dr. Sheth's work, but very conceivably it could be performed by a small group of nurses or maybe even techs who are just trained to use the iPad. Next slide, please, Sam. So we look forward to the future opportunities that come with this. Here is, for frame of reference, an example of a patient with ischemic changes in the left MCA territory designated by the arrows, and you can kind of see what a small watershed acute ischemic stroke looks like on the device, which has undergone tremendous evolution since the original pilots came out in terms of imaging resolution and quality. So thank you very much, and we can turn it over to the next speaker.
Thank you so much, Dr. Wira. It's very exciting to see your progress and how far you guys have come already. We'll save some questions for the Q&A afterwards. To keep on time, we'll just go ahead and introduce Dr. Christopher Raio. He's an emergency physician at Good Samaritan Hospital in Long Island. Dr. Raio, the floor is yours.
Thank you very much. So my name is Chris Raio. I'm chairman of emergency medicine at Good Samaritan and chief of emergency medicine for Catholic Health of Long Island. And for background, I am ultrasound fellowship trained, so definitely have a keen interest in point of care imaging, and that's one of the reasons why I'm so excited about this device, because I really think it can be a complete game changer. Next slide. So, I am a practicing emergency physician, as I'm sure some of you on the webinar are, and we all know the clinical utility for MRI. Stroke obviously is the thing that comes to most of our minds initially. Also the evaluation of the spine, maybe appendicitis in pregnant patients. And then there's a host of other musculoskeletal related disease processes and injuries where MRI can be super, super useful. Obviously no ionizing radiation, and you can think about some specific patient populations such as pediatrics and pregnant patients where MRI can really help you and help you get to your diagnosis. I think the problem, even though CT and MRI, the use in emergency medicine has certainly been increasing over the past 5 to 10 years, is really MRI is underutilized, and it's underutilized primarily due to cost and accessibility. And even though those numbers are increasing, it's still oftentimes not utilized when it should be. And I think it's important to go back to that mission statement from Hyperfine, right? This is not just for my, big tertiary care center. It's not just for Dr. Wira's emergency department at Yale. We need to think more globally. And if it's not always accessible for me, on a day-to-day shift, just think about all those underserved areas across the globe and all the opportunities that Hyperfine can bring. Next slide, please. So, the clinical reality, thinking about, shift work is, you look at your board, you see these complaints: dizziness, headache, back pain, tingling, numbness. And some of those things, when you look at them, you say, oh boy, this is going to be a little bit difficult of a patient. You might think ahead to what imaging you might need, and MRI just is not always there for you when you might want it. And I think sometimes emergency physicians think, wow, I would love to get an MRI, but I know, I'm going to have to talk to a radiologist, I'm going to have to talk to the tech, I may have to argue, I may have to wait 6-7 hours to get it done, and they wind up, maybe taking a shortcut and going around it and not getting that imaging done that they really should. These are challenging cases. The other thing, from a risk management perspective, a lot of cases come up revolving around neurologic emergencies, neurovascular issues, and there's a big role for MRI coming into play here. And again, we need it accessible. We need it accessible for every clinician, and not just in the United States, but all over the globe. And I think Hyperfine can play a big role in that. Next slide. So there are obstacles, right? There are big obstacles, and some of these are what Hyperfine really is targeting. Cost. So we talk about, potentially a 20-fold increase in cost when you're talking about traditional MRI. And it's not just equipment costs, there's also staffing costs. I'm going to show you how easy it would be to actually operate the iPad to perform one of these exams. You could potentially eliminate huge staffing costs with MRI there. What about those patients who we say, and if this happens every day during one of my shifts, you need an MRI, but I can't get it done today. In the emergency department, really I can only get an MRI done if it's a life or limb-threatening emergency. So that patient then has to be discharged home. They have to go to their primary care doctor or to a referred specialist, take a day off from work, then they have to get a referral, then they have to take another day off from work to go get the testing done. There's a lot of other costs that we might not always think of as an emergency physician that goes into this, that Hyperfine can help solve some of those issues. There's the time issue, right? So we think, the scan time for Hyperfine is, 30, 35 minutes. When you're talking about traditional MRI, if you have to go, a mile away to the MRI suite, there's transport times, there's waiting for the transporter. So that becomes a problem. There's space. So, you need an MRI suite. So you need to have that space available. A lot of these patients can be critically ill. So, doing a point of care imaging test has a lot of benefits, particularly in an unstable or critically ill patient. You need the technology, you need the technician. There's also a lot of flow issues. So, waiting hours to get an MRI done, to get an MRI read, that has huge length of stay issues, not just in the emergency department, but also in the hospital. Think about creating bed capacity by getting this testing done in a much more efficient manner. It can open up bed capacity in your own department and throughout the building. And lastly, there are many patients who simply don't want to get a traditional MRI done. We talked a little bit about the noise factor. It's significantly better with Hyperfine. Claustrophobia, you still are in the system, but most patients have reported to us that it was a lot more comfortable than going through the traditional MRI process. And body habitus, we've only seen one patient who we were unable to scan, and that's because they had a severe kyphosis, and that's across my site and Jerry's site. But you know, body habitus has not really been a major issue for us utilizing the Hyperfine. Next slide, please. So this is day one. You could see how easy it is to drive the Hyperfine. My model is actually joystick operated and motorized. Really easy to transport. You see Sam following me there to make sure I don't crash into anything. This was my first spin with the system, but super portable and certainly easy to get around from department to department. As we were going here, we were actually going from our neuro ICU down to the emergency department, but also you can maneuver from room to room within a department. Next slide. I think ease of use is something that really needs to be stressed. So this is what you would see on your iPad. You could see the protocols there listed on the left. It's as simple as clicking on one of the protocols, and then it would list out the details on the right there as to what's involved with each protocol. A lot of these things are you know, customizable, so you could certainly change things around once you get used to the system and used to what you think works best for you and for your patient population. Next slide. Viewing the images is just as simple. So this is a screenshot right off my computer. There you see a lot of the cases that we had done here at Good Sam. You would simply click on the little eyeball on the right side of the screen. It would pull up all your images like a traditional PACS viewer, and super, super easy to not only perform the exam, but here to actually view your images and get your results. So here at Good Sam, we have two systems in-house. We have one system up with Dr. Kimon Beckless. He's a neurosurgeon specializing in stroke care, so we store that system up in our neuro ICU. And then we have another system down in our emergency department. We have both the head coil and the foot coil. The feedback has been overwhelmingly positive. So from the patients, they really have given positive feedback from the fact that the scan is done in their room, oftentimes with a patient or family member, you know, nearby that they can actually talk to. As the physician involved, you know, myself or my physician assistant or resident can, you know, check in on the patient during the exam, you know, give us a thumbs up to tell us, let us know everything's okay. And the patients really, really like it. All of our exams, different from Dr. Wira, have been performed by either a physician or a physician assistant. And again, super simple to do. You know, the most time that we spend is really just positioning the patient, and that takes only a few minutes. And once the patient is comfortable, you simply press the button on the iPad and you're off. So it's been really, really positive for the individuals performing the exams as well. Where we've done a lot of our clinical exams is in our clinical decision unit, our observation unit. We found that about 20% of our patients require an MRI, and if you look across the literature, that's pretty consistent. And we found it to be very valuable. We talked a little bit about the enthusiasm, and I would say a shift doesn't go by where my nursing and ancillary staff don't ask me, hey, why can't we just use the Hyperfine? Why do we have to send this patient off to the MRI suite? You know, we often wait hours to get those traditional MRIs done, and you know, that staff is seeing me perform these exams and seeing how we can get these tests done much, much quicker. And the enthusiasm I see is let's start using it more. Right now, we're really scanning under IRB. So a lot of these patients are getting the Hyperfine scan and the traditional. But in the future, obviously, we hope to just switch over to just using the Hyperfine. Next slide. So I think it's important, you know, this is very new, right? This is new point of care technology that is super exciting. I think we all, you know, once somebody says portable MRI, things start to spin around in our head. You know, oh, I can use it for this. I can use it for this. I've seen my neurology and neurosurgery teams, when they see me using it in the department, they call their colleagues and their attendings to come down to check it out. Think back 20 years, and I actually have the actual system that's in that picture. This is the first point of care ultrasound machine that was purchased by my department in the year 2000. Point of care ultrasound now is ubiquitous throughout emergency medicine. I would be shocked if you hit a department that didn't have a machine. And, you know, we fought through a lot of political battles, a lot of hurdles. You know, we've been pushing things on the research envelope so that people are more comfortable with point of care ultrasound use. I see MRI as the same. I think, you know, hopefully in a shorter time frame, hopefully a couple of years from now, you know, we look back and see the evolution of point of care MRI similar to the evolution of point of care ultrasound. And I hope to see this in a lot of emergency departments, not only across the country, but across the world very, very soon. Thank you.
Thanks, Chris, so much for painting that clear picture of all your pain points. And it's really nice to hear how easy it is for you to implement the Hyperfine device into your workflow. Okay, so last but not least, we have Dr. Jerry Chiarcolo. He's a emergency physician doctor at York-Presbyterian Brooklyn Methodist Hospital. And today he's going to talk about his experiences with the Hyperfine device. Jerry?
Oh, thank you. And first off, I'd like to thank Sam and the entire Hyperfine team and my co-panelists, Chris and Charles, for inviting me and allowing me to talk on this, in this session. I got to say, just like Chris, I'm also ultrasound fellowship trained, and I have the same passion for him for new technologies and how to improve, our efficiency and care that we give at the bedside. So when I was first made aware of Hyperfine and a portable MRI machine, it actually piqued my interest tremendously, and made me want to investigate really how feasible it was to do in the emergency department, and how it can really impact our daily lives moving forward. So the emergency department I work in is 100 to 10,000 visit ED, very high volume, very high acuity, stroke center, comprehensive stroke center, STEMI center, level 1 trauma center. We, very busy with high acuity. So I thought, what better way to really put the machine through the rigors than to incorporate it into my emergency department in an urban area. So next slide. So, I know actually next slide. I know that there's a lot of emergency physicians on this webinar, and everybody's familiar with this, right? The board, and everybody's also familiar with the pain I was feeling this day. I'm in orange, and I felt like I was seeing double to triple the amount of patients my colleagues were picking up. But we all have those days, right, where we kind of really feel busy and really feel like we have a lot of patients with complaints, with nebulous complaints, I should say, or kind of something you really can't pinpoint, and the generalities of it. And you look at this list, you see headache, you see viral meningitis, which got changed from obviously headache and malaise until we put in our final diagnosis. You see unresponsive, slurred speech, weakness, syncope, near syncope, fall with head trauma, another dizziness, keep going down, another headache, another fall with head injury, lethargy. So I guess you guys kind of get my point. I want to kind of hammer home really what Chris was saying. This is a real world board, and on any one of our shifts where you can see out of that list how many people could possibly benefit from an MRI. But what happens? What happens is we usually default to CT because it's easy, quick. And we all know about the inherent risks of CT and the ionizing radiation and, the contraindications to pregnancy and especially early pregnancy and everything. So But because MRI is not so available to us, and because there's a lot of obstacles to get to it, we typically don't perform them. But I think a lot of us would if it was accessible to us on a lot of these patients, especially like Charles was saying with the posterior circulation symptoms, including vertigo. You could do as many HINTS exams as you want. Your gut sometimes tells you you're worried that this might be a cerebral vascular accident of the posterior circulation, and you'd really feel more comfortable getting an MRI before you try to send that patient out. And in my particular institution, a lot of times they get admitted. We don't have an OBS unit. We can't get an MRI, especially after hours, and a lot of times not even during hours unless it's a true neurologic emergency. So they wind up getting admitted. And going back to Chris's point about hospital length of stay, that adds at least another day, if not two, takes a transporter out of the mix because they have to transport the patient down, sometimes even with physicians, sometimes with sedation and specialists like anesthesiologists when you're talking about kids. The amount of people, and you take the technician out, you take the MRI machine out of commission for another patient, and things start to back up, and it really then starts to trickle down to the ED in terms of borders and holding patients. So next slide, Sam. So even on a slower day, you could see, and anybody who's worked emergency medicine knows they love that top complaint, right? Complains of smoking crack. You could see eye swelling and irritation, but a lot of times that could be periorbital erythema, facial rash, fall, head injury. So, you can't think of just a short term, can't put blinders on, just think stroke. I see the potential in this, things like orbital cellulitis, deep space neck and facial infections, obviously head trauma and head bleeds, really so many indications that really don't even cross our minds anymore because we're so accustomed to getting other imaging modalities because of the obstacles. But if the obstacles start to fall, next, Sam, then, why not CT? Well, why? Because if you go to the next slide, all the contraindications, like I said before, and here's a real case, and you hope that this isn't yours. But you can see it's some pannus, abdominal pannus, a larger patient who came in with back pain, was asked if there's any chance of pregnancy. She denied it. They did a UCG and it was negative. And because of the way the clinical course developed, they decided to get a stat non-contrast CT. And you can see here a fully gravid fetus in the abdomen, now exposing baby and mother to ionizing radiation. And you could let alone all the meetings and concerns that came out of that. But I think the take-home point here is that CT always isn't the answer. It's become the answer because of the obstacles to other imaging modalities, but it always isn't the right answer. Next slide. So how are we overcoming these obstacles? Well, I said, work in a very urban, very crowded, very tight emergency department, and most of our spots are doubled up, sometimes separated by a single curtain, sometimes not. And here you can see me using it in real life with a patient. The patient next to them was the happy face, actually was very interested, looking up, actually asking if she could get an MRI after the patient. You can see we do them with monitors in the room. You can see that, and we've done 60 plus patients in our feasibility study, and we haven't had any interference with any of the medical devices. We haven't had any complaints from the patients or the patients who are sharing these bays, with the patients getting the MRIs. Next slide. As Chris alluded to earlier, we tend to have some patients with larger BMIs in Brooklyn, probably unlike a lot of the other emergency physicians. I'm sure all of your patients are healthy and fit, but sometimes here in Brooklyn, we have some patients with higher BMIs. And I can tell you, not only do they fit into the machine well, maneuvering them in and having themselves help position inside, and any of the claustrophobia concerns that we've heard from conventional or traditional MRI really hasn't panned out with this. I've had no patients really abort their consent for the feasibility study due to any kind of claustrophobia concerns. And the fact that the family members can sit in the room with them and hold their hand and keep them company has made everybody really just tremendous patient experience and nothing but resounding feedback. But, size of patients, space for the machine in the tightest of emergency departments has not been an issue. Next slide. One of the real pressing issues on why I really wanted to investigate this and what my next study is going to be is on diabetic feet. And as Chris mentioned, there's a foot and ankle coil available to this machine right now that we're investigating. And so we see a lot of patients with very large edematous cellulitic feet with ulcerations who wind up getting admitted to the hospital and spend an excessive amount of days waiting for MRI, waiting for cultures, blood work, wound cultures, getting some IV doses of antibiotics. And I think when you have about 3 to 5 patients of those a day, if you can, mitigate that number, get that number down, it can only help hospital throughput, which then in turn affects ED efficiency and throughput. So this was one of the things I really wanted to focus on. And you can see here, patient in the ED, sitting up comfortably, foot in the coil, half-hour scan, getting really, really nice images. Next slide. So I just wanted to give some good representation because my final slide I'm going to end up with was the data that we reported and we submitted for publication and for presentation at a national committee, at a national conference, I should say. So, here you can see a very acceptable image quality, a T1 weighted image, right? I believe, hold on, of one of our patients that we scanned early on in the course. If you go to the next slide. And here you see a nice flare, a fluid attenuated image, where you can see that the CSF is dark. That's why it's not a T2 image, but look at the image quality was very acceptable to us. We included, I'll kind of go over the study in 2 more slides, but we included pretty much anybody with a acute neurologic complaint, and just to see if it would kind of, be feasible to perform these in a timely manner and to make sure that the image quality was acceptable. Next slide. Here's some AI that can come with the, this is a T2 weighted image, and you can see the CSF is bright white, but you can also see that there's some artificial intelligence helping with the size and contents of the ventricles, also kind of tell you a midline shift. So as the technology develops and grows with us in the emergency department, there are tools to help, because I am not a neuroradiologist, I am not an MRI physicist. So, any kind of assistance that I could get, especially early on, is definitely appreciated. But I could tell you from seeing a lot of patients, knowing that I could tell when an image quality is acceptable and I could search for the things that I'm looking for. Next. And here's a couple of representative images of the feet, right? That I was talking about, what I was worried about. So clearly good image quality. We'd be able to see if there was any edema, if there's any cortical disruption, any kind of signs of acute infectious processes. And I would also imagine that it would be really good in the setting of trauma as well. All these things that we're going to be investigating in the very, very near future. Next slide. Here's another image of a foot, again, highlighting a little bit more of the soft tissue with the osseous structures. So when you're concerned about osteomyelitis, looking at the adjacent soft tissue is a key component to making that diagnosis. On top of the marrow edema, the cortical disruption, a lot of times there's inflammatory changes and even microabscesses and the abscesses in the soft tissue near the infection. And I think this image really highlights out that we'll be able to point it out very apparently. So final slide. Oh, didn't make it in there.
Yeah, I don't think that one made it in there, Jerry. Do you want to share real quickly what it just is?
Oh, well, I can't, I don't have it on this computer here, but I could talk about it. So we did a study where 2 physicians and then followed by 2 research associates were trained to maneuver the machine and acquire images. The sequences were dictated by the physicians. We did a 3-question survey upon completion of the IRB approved study. Was number 1, is the machine easy to transport and to set up for use? Question 2 was it easy to position the patient and acquire the images? And then 3 was that the interface was easy to work and to acceptable to the physicians. And 90% agreed or strongly agreed that it was easy to transport. 89% agreed or strongly agreed that it was easy to position a patient, and 100% agreed or strongly agreed that the user interface and the performance of the MRI was simple to use. And I think most importantly, and we'll hopefully get to in a further study, but 89.5% of the exams were deemed acceptable by an uninvolved third-party physician reviewer. So, easy to use, easy to acquire images, easy to navigate the patients, all with acceptable image quality. It really sets the page for the clinical studies that are to follow and hopefully show what this early study indicates is that there's going to be a huge role for Hyperfine in the emergency department. So sorry that slide didn't make it in, but with that said, I thank you all very much for your time, and I pass the baton back to Sam.
Thanks so much, Jerry. I think a lot of people will be interested in seeing that ASAP abstract come out. It'll be very interesting. So we are getting close on time, but we'll just take a round of questions. And any questions we don't answer, we will compile and we'll distribute them after this webinar. So you will get your questions answered. One of the first questions, maybe Chris, maybe you can take this question. Someone's wondering if you could describe kind of the screening process that you've done with your patients and whether or not the device can be used with implants like pacemakers.
Yeah, so I mean, we actually just mimic the screening for traditional MRI. The risks are much, much lower, and maybe somebody from the Hyperfine team can talk specifics, but from a safety perspective and just rolling this out as a research study, we actually use the same screening as for traditional MRI, and we did not scan patients with implantable devices.
Yep. Yeah, I think for these IRB studies, we've been very cautious, and since it's a new device, the radiology departments are usually questioning it, but we're really only concerned about active implants, and we can follow any of the labeling on any of these devices. So anything that says it's okay for 1.5T and below, those devices are completely safe with the Hyperfine device. There is another question on here about scanning in the ambulance. So Charles, maybe you could answer this kind of more broadly about, do you see any opportunities and maybe some potential challenges and hurdles to overcome with potentially putting the Hyperfine device in an ambulance?
I certainly think that there are future opportunities, but think that, like for CT in the era before mobile stroke units, there's going to have to be appropriate pilot studies and investigation just demonstrating the safety to the, not only safety to the equipment, but safety in general. And CAT scan, as you may know, I mean, there were a lot of preliminary studies for multiple stroke units that had concerns about radiation exposure to the ambulance team and staff, radiation exposure to bypassing people who may be walking by or driving by the mobile stroke unit when it's actually scanning. So MR will not introduce those challenges because it's not radio ionizing that's being performed. Safety to the magnet, that I think is a valid thing to question, as I saw in one of the comments. Certainly, I think the clinical utility for certain patient populations will be, helpful to, potentially rule in or rule out the presence of ischemia. And certainly, I mean, if you have a future mobile stroke unit that's empowered with both, CT angiography imaging as well as an MRI imaging, then it really would be poised and essentially would be a mobile acute stroke ready or primary stroke center, having both of those diagnostic options, because certainly for some patients, one option is more favorable than the other in terms of the early hyperacute evaluation. As we know, some stroke centers like Mass General and Brown, just anecdotally from knowing people there, are incorporating early magnet MRI use in their stroke protocols for certain patient populations. And certainly for patients with an unknown time of onset of stroke, like we said in the very beginning of our talk, MRI can serve as a fairly accurate witness for when the onset of a stroke occurred. So for wake-up stroke patients or unknown last normal, having a magnet on the mobile stroke unit will certainly enable a more accurate timestamp than, say, utilizing CT criteria like an aspect score or some other surrogate marker for stroke onset.
Thank you so much. So just for the sake of time, I'm going to just ask one more question, but again, we'll distribute the list of all of these questions and answer them after this webinar. There's been some questions about the coils that we have, and just want, Jerry's mentioned that he has a foot coil. That is a works in progress, and right now the device comes with just a head-only coil. But Jerry, could you comment a little bit about how you change out the coils and how you load the patients?
Absolutely. So the coils are as simple as, you know, sliding the coil out and unplugging it and plugging in and sliding back in the other coil. I mean, extremely simple to change. And the positioning of the patient, it really depends on if it's the head coil or foot and ankle coil. They are sitting up in their stretcher comfortably with their foot in the coil for the foot and ankle coil, or they are laying on their stretcher slid back with a nice comfortable pad to brace their legs, padding around their head and upper body to make them comfortable during their MRI of their brain. I've had zero complaints for comfort on any of the patients who have gone in for either head or foot and ankle. Simple to change out and simple to position the patients.
Thank you so much. Well, I want to just take the time now and thank everybody for joining us today. And of course, I want to thank our three panelists, Jerry, Chaz, and Chris. Your insights have been tremendous today, and we really appreciate you being here. So this will be posted again, and you'll get an email that was sent for your registration afterwards. So you'll be able to follow and ask any more further questions there. So with that, we're going to end this webinar right now.
Thank you.
Thank you.
Have a great day.